Hello everyone, welcome to today's lesson. We are going to be focusing on how World War One has led to progress in surgery. Loads and loads of examples of how surgery and medicine has improved thanks to World War One. Loads of bodies to practice on, things like that. Loads of practice of sources available in this lesson as well. Take your time going through this. This lesson alone could really secure your skills and your knowledge to basically answer most questions in the exam paper on the trenches section, especially if it's related to treatment of injuries and wounds. Okay, so with that said, let's get started. This is a really fascinating lesson. There's lots to get your head around, so maybe you want to watch a little bit at a time, master each bit of it, or watch the whole thing as an overview and then try to consolidate your knowledge as you go. All right, so what was the significance of World War One is the question that we're asking. Would these things have happened in medicine and surgery had it not been for World War One? So as a factor of war, we've met the factors, haven't we, in the medicine course? We know how these factors have contributed to medicine getting better or not. So it's really quite impossible to say that war has not played a part in the advances in medicine and surgery, especially some of the examples we're going to look at in this session today. Okay, so let's get into it with the first couple of examples. But before we start, let's think about the biggest killer in the trenches in World War One was infection of these wounds. Okay, so we are considering obviously the most important thing, that the place that they are most of the time is muddy fields, muddy conditions in the dugouts. One of the biggest problems facing the RAMC was infections. This is caused by this gas gangrene or the infection inside the body. We can see these photographs here. We can absolutely see without any doubt the impact of the infection, the gas infection inside the body, not to be confused with impact of gas attacks, remember, of chlorine and mustard gas. This is the name given to the infection inside of a wound. All right, so aseptic surgery, is it possible? If not, why not? Have a little think. Obviously, you don't need to pause the video so much for this because it's a more of a quick thought question, but it's not possible really out in the fields, is it? We're in the fields of France and Belgium. It might be possible in a base hospital, perhaps, where some surgery is taking place, but out in the field, it's generally not possible. So this is going to lead to all sorts of infections from quite minor injuries, really. A little nick here and there, perhaps, and a bit of barbed wire. So this becomes the biggest problem, as we know from the previous trenches course. So contaminated conditions, the sheer number of wounded men mean that it's impossible to keep the place as clean as possible to try and avoid further infection, especially along the evacuation chain. So this is the problem, and of course this whole story is about solutions in how we get ourselves to fix this problem. All right, so we'll now look at some examples of how they dealt with the gas gangrene and the infections and saved a lot of lives. All right, so before we do that, just imagine that you're a soldier. You've arrived at the ADS with a severe infection. There are signs of gas gangrene already because it comes quickly. What are your options? Just pause the video and write down what we can do for this soldier at the ADS. So the advanced dressing station, he's obviously just popped through the wrap, and this is the second stage of the evacuation chain. Make a list of what might be able to be done for this patient who is clearly showing signs of an infection already. And then we will find out what the new ideas were. This is a interesting little story from a doctor at an RAP, and he recalls how he dealt with it previously at the start of the war. He says the only thing you could do was cover the wound to keep it from getting infected and stop the bleeding by compression or by putting a tourniquet around the leg or the arm. Now, we know all of these things happen at the RAP. If it was shot off and bleeding profusely, so non-stop, you had to stop it by putting a tourniquet on. But you couldn't keep a tourniquet on longer than an hour because then they'd lose the leg altogether, because obviously you've stopped the blood supply. So it's really important and very necessary, he says, to get the field ambulance, the stretcher bearers, so they could get their blood vessels tied off. The quicker they do that, the more chance you have of survival. Within minutes, ideally, of this blood loss. So what he's saying here is, in the early days, the only real chance you had when dealing with certainly blood on a massive scale is to try and cut off the artery from bleeding or block it off. The tourniquet was good for a short amount of time, maybe from the RAP to the ADS perhaps, but by the time you get to the CCS, a lot of damage is probably already being done. So maybe that's what you've written down in your little list of how you solve this problem straight away, but this is not effective, this is not helpful, and certainly after a big battle, there just is no way the field ambulance can do this to all those soldiers. All right, so the treatments did improve. Let's see how they improved, okay? Firstly, we look at the overall options that we now have. All right, so if you're watching this because you missed the lesson, in your Google Classroom will be this image. We'll get this stuck into your book as well. If you're watching this as revision, then obviously this will hopefully come back to you, this little image here. So another huge problem is the wound infection. That is the biggest problem, we know that. Operations are taking place in old buildings, shelters, dugouts, wherever possible. We know that aseptic surgery, as we've said, is just not possible. We know that there's been some progress in aseptic surgery from the medicine course, but we're in the trenches, okay, as we've said. Many of these cases, the gangrene would start really quick and spread into the tissues. The only way to prevent it, really, is to chop the arm off. And we can see that here on the bottom left, amputation. That's the option of 3 that we have here to stop the infection spread. And just chop it off, okay? Now, perhaps you might want to try the 2 other things that we'll see first, but ultimately this is going to end with amputation if we don't solve that problem first. And ideally, we want to keep these guys with their limbs so that they can recover and hopefully go back to the war. So then the first option then, before we have to chop the leg off or the arm, is to excise it, to cut away the infected tissue. Now, just the thought of that in itself is pretty rough, but it's quite standard today, common. Partly because it was mastered, really, in World War I. So you've got to do this as soon as possible because, as we've seen, the infection can spread super quick. So you excise the wound, you cut it out, and then you need to close it by stitching, all right? If any infected tissue has not been removed before it was stitched, the infection would just spread again, and we'll have to do further operations down the line. Keep that in mind for later on in this lesson when we look at a source that talks about having to have surgery redone. All right, and partly that might come down to the idea that there's just too many men to be working on. So perhaps just pure time alone, the doctors aren't able to do a good enough job. So in summary, option 1, before we chop the leg off, would be to cut the wound out, the infection out, once we see the gangrene, and then make sure it's clean before we stitch that thing back up. But again, the risk is high because these things are being done in old abandoned buildings or in a tent or somewhere like that. So then option 2, and this new idea, all right, so 2 guys got together. It's called the Carroll-Dakin method. We'll talk about that in a bit of detail in a minute. But in a nutshell, what it is essentially putting some salty water into the wound. All right, so it's used instead of trying to use some sort of carbolic lotion. We know that we tried that in the medicine course, but it's not practical out in the trenches. So we basically wash out the wound with this sterilized salt solution, salty water. The solution does only last for 6 hours though, so it has to be made as it was needed. So you're going to sit there and have this salty water pumped into your wound and hopefully clean out the infection and stop it spreading as well. Of course, as always with these things, after a particular battle, if it's a big battle, you just haven't got the men to be able to do this, so infection rates are going to go up. But this is a new method of trying to avoid infection. And then, of course, if 1 and 2 don't work, then as we've said, the ultimate is amputation. All right, so let's have a little bit more of a detailed think about this Carroll-Dakin method. It's an excellent features question 1. Any of these things, give 1 feature of how they treated infection and wounds in the trenches. Pick 1 of them. All right, you might remember the amputation one because it's most obvious. Wound excision, that's quite a nice little story to tell for 2 marks. But the Carroll-Dakin method gives you some really nice facts and a really nice story to think about to guarantee your 2 marks. All right, so this image shows us, it's a cartoon, but it gives us the idea about how the Carroll-Dakin method is working. So to solve the problem, surgeons used a similar approach by Dr. Alexis Carroll, a French field surgeon, and Henry Dakin, an English chemist. They joined forces and come up with this brilliant little idea. And it seems so simple, but it worked. And the idea is keeping the wound clean, of an open wound especially. So they tried all sorts of things. Dakin suggested a hypochlorite solution, which would serve as an antiseptic. The Carroll-Dakin method, therefore, is now used during the Battle of the Somme. Firstly, it clearly works. Cases of gangrene drop. In fact, gangrene, just infection. And it's quite a brilliant breakthrough because obviously before that we are either going to be chopping limbs off, losing soldiers, affecting their lives forever. We have this problem solved really simply by using some salty water. All right, so that's the gist of the Carroll-Dakin method. It might be worth actually just pausing the video now and having a quick practice. Maybe write all 3 of these features and perhaps do that for the whole lesson just to guarantee you've got a load of practiced questions already for that question 1. So 1 feature of how they treated wounds and infections. You could do Carol Dakin, wound excision, and amputations. When you've done that, if you choose to do that, unpause the video and carry on. And remember, get everything that you do marked by your teachers just to make sure that you are on the right track. Here's a source to practice with, and the whole of this lesson is basically you having the chance to stop, think, and pause and put everything into action. So this is quite a big source, probably bigger than you might get in your actual exam, but still have your normal practice. Pause the video, try and pick out some content, tell the story of BC Jones. What conclusions can you draw from the fact that the soldier in this source needed to have a limb re-amputated when he got home? And then make a list of questions that you could ask for this. Remember, our questions in the follow-up question of a source, the questions really need to be quite vague, big. The whole Western Front, like how many soldiers were treated by the Carol Dakin method or something like that? How successful was the treatment of using amputations? Something like that, not just one person's experience. And then the source that we use, remember, generally speaking, 90% of the time will be RAMC medical records from a CCS or a base hospital. It's not always the case, but it's certainly most of the time we could get away with that. So pause the video, do some content, pick out some bits, tell the story basically of what's happened here, and then think about those questions that we can ask, especially for the follow-up question, okay? Also, make sure you do understand, try not give an answer for that. Why has he had his limb re-amputated? What's led to that? This is you making an inference, isn't it? Okay? How could we then follow that up then? So if this is the question, the third question of the trenches paper where we have to follow up, we get this sort of writing frame, don't we? Where we have to decide a detail in source A that I would follow up with. Then we have a question that we'd ask. And then we have to have the source that we'd use. And then how might this help answer the question, all right? So you have a go at this one as well. Again, this whole lesson really is quick details, quick facts about each of these new breakthroughs, but then you doing something with that really to secure and consolidate the knowledge. So if this was about treatment, I might pick for source A, operation on upper arm for gangrene successful. All right, that's what I'm picking out. That's the source. The question I might ask about that might be something along the lines of how did they operate on gangrene in the Western Front? So a big question, how do they do it? The type of source I might use, RAMC records from a base hospital or a CCS on the Western Front. Make sure we're including on the Western Front every time. And this might help answer my question because it'd be something as simple as it will note down in these records what operations were done for soldiers who had an infection, and I could work out an average, which did they use more often than not, or something like that. So there's a good example of how we get our 4 marks for that, but you've got to be really, really specific with the source, but really, really vague and open with the question. But make sure you don't lose that first mark, which is just you picking out a quote from the source, okay? And also remember to make sure that it's focused on the question, in this case, treatments on the Western Front. All right, so hopefully you having a bit of a practice or listening to our example, that makes you feel a little bit more confident on that question. It does worry people a little bit. I think it's because it's so random, really. But that is essentially what historians do in real life, isn't it? So when you're ready, we'll move on and we'll see what the next advance is in the trenches. The next one is the Thomas Splint. In 1914-15, the first year or so of war, men with gunshot wounds and shrapnel wounds had about a 20% chance of survival. That's like no chance at all. We know, don't we, from our injuries lesson that the legs and the arms are the things that are sort of open to the elements. That's why they generally get most of the damage. These wounds would cause compound fractures where the bone comes through the skin, causing major bleeding, broken femurs, the thigh bone, especially they're dangerous. So this splint that was used at the start of the war did not keep the leg rigid. All right, they've used splints all through time. Cave people, there's evidence that cavemen use splints on broken bones, but that actually made things worse. By the time the wounded men arrived at a CCS, he'd probably lost loads of blood already, and that's the biggest problem here with the Thomas Splint is blood loss, actually, and has gone into shock. He might already developed a bit of gas gangrene. We know how quick that spreads. So this reduced the chances of surviving an operation to the wound, hence why only 20% of them survived. So the way they improved the survival rate of men with this injury was basically this guy called Hugh Thomas. He designs a splint that stops the joints from moving. All right, that's why this is important. It's not about helping it not the broken bone at all. That's what you might immediately think. It's to stop the joints moving. If you have got a compound fracture and you've got bone rubbing against bone, against flesh, and every time the ambulance goes over a pothole or moves and it's cutting into your flesh even more, you can understand how the damage is getting even worse, can't you? All right, so the idea of this thing was to try and keep the leg as still as possible to avoid any of those fragments of bone from getting all over the place, causing even more damage and more blood loss. And think about this as well, just before we do move on. This patient who's lying in the middle of a battlefield with this broken leg, bone sticking out everywhere, must have been terrifying, must have been horrendous. So to improve the speed and efficiency of this, the stretcher bearers, the field ambulance, they were trained to put the Thomas splint on blindfolded. This is going to be really useful, isn't it? Especially when tendon wounded soldiers at night. After this, the patients would be in the splint and hopefully they'd get along the evacuation chain without any further damage. And they'd be in there, generally speaking, for about 3 to 6 months, okay? Many of them still walk with a limp later on, obviously, but that's better than dying out in no man's land, okay? So the Thomas splint is another really nice story to get your head around, and this diagram really sets it up quite nicely. It's an oval ring with padded soft materials that goes through the leg up to the groin. The wound is then covered to prevent infection and secure strapping put in place with these iron rods down to the splint to keep your leg straight, and the iron bars at the end to sort of raise and keep it suspended. So a really simple actual device, but it's about blood. Remember, trying to stop less blood. It's about stopping the bones, ripping the flesh even more. It's about keeping it still. So it's not necessarily just for what you might think about keeping broken bones. All right. Still. So basically, this is where we are. 1914, 1915, to summarize, you got this 20% chance of survival. Hopefully that's a nice fact that's stuck in your head. And the reason for that is that these compound fractures, as we've said, they pierce the skin and they're out in the open, probably rubbing together, ripping the flesh a little bit more, also leaving bits of, cotton from your clothes in there as well. And if the thigh bone, as we said, is the biggest bone, is fractured, this would lead to muscle damage and bleeding into the thigh. Every single movement that you're on the way up the evacuation chain, you are cutting the flesh even more. So it's simple, all right? Here's an example on one of our patients on the battlefield strip. You can see how the thing is. You can see the bone in the little wound there, and it's about keeping that thing as still as possible. So we'll have this little source, just as any opportunity to get sources into our story, because it's important, isn't it? From Alice Remington, an ambulance driver. And remember the nurses, we know they drive the ambulances along the evacuation chain. So this is a nice reminder, but listen to what she says. And these things are obviously incredible sources because they are the voices of the people that lived through it. She says the groans of the people in pain are very distressing. Now, we've seen sources where when Fanny goes to war, she described, didn't she, the pains and the wails of the men in the back of the ambulance after every pothole they go over. She says there's not much you can do except get them there without making their wounds worse. She's trying to drive this thing carefully, slowly, not get it, jolting about, because every time they jolt about, there's bone that could rip the flesh. If you drove too fast, there's fractures. You might make it worse. If it's a chest wound, you couldn't have any ribs or anything puncturing lungs. So she's describing here the problems of transport. And we've already mentioned that in the previous lessons. But it's always good to think of the bigger picture when we're doing these things. And she's describing a really serious problem there. And so you can see then with the Thomas splint on, that's going to increase the chances, isn't it, of survival. So this is where we are. 20% of these soldiers are dying. They originally use splints to keep the leg rigid. That was the idea. We've seen that, but that led to loss of blood and shock already by that point. So the leg amputations would be done at the CCS, remember, because they got so good at operations, and that takes pressure off at the base hospital. But even still, with a big operation or a big battle, that's still going to be quite hard to keep up with that. And then the Thomas splint, just to summarize one more time, is designed to stop the joints moving, not to keep the broken bone still. All right, so what do you think? Just pause the video and write down a number really quickly in what you think the Thomas splint did to survival rates. If before the Thomas splint, only 20% of people survived, what do you think survived afterwards, okay? When you're ready, unpause the video, and hopefully you'll be in for a pleasant surprise. This is a massive change. All right, so survival rates have gone up from 20 to 82%. This is utterly mind-blowing. Just to think about a simple injury that was killing 80% of people is now only killing 18% thanks to this Thomas splint that keeps the leg still or the wound still. Obviously, the leg, generally speaking, will be used for a Thomas splint. I'm sure they were clever enough to adapt to other parts of the body as well, but generally speaking, it goes up to the thigh of the leg. All right. So number 3 then, x-rays. Now we've already talked about x-rays in this course. We know we've got some x-rays at the base hospitals. We know that they're big and cumbersome and take a long time and they're very fragile and they cause radiation poison and all those things, but we know we have them. By 1914, the doctors have realised that the x-rays are going to be useful. We know that. They can see where broken bones are, they can see where bullets and shrapnel maybe are in the body. It just makes things a whole lot easier. All right, so now we know that we've got these x-rays in the base hospitals. That's not really too helpful when you think about the amount of men who are injured with shrapnel or bullets in them, and they have to wait till they get to the hospital to get this seen to. So now we get the mobile x-rays, and obviously it goes without saying it's an x-ray that's mobile, which can get closer and quicker to the soldiers, usually at the CCSs. So they are used to locate broken bones, we know that, as well as fragments of shrapnel in the body. Surgeons no longer need to sort of root around inside the body for that and take time. They can go straight in. All right, so this is what the mobile x-rays features will be. Again, lovely question 1. But all of this, don't forget, will become your own knowledge in a source question. And when you're struggling, if you're struggling for the source question, remember that the sources will remind you a little bit of what you need to think about. They'll hopefully trigger a memory that allows you to, oh, I know what this is, and then get some marks that way. So we know why they're used initially, but just know the problem is that they're in the base hospital only. They are dangerous to the skin, they burn. They are too big, they take too long to take a picture, up to 90 minutes to take an image, and then the tubes become very fragile and overheat very quickly, meaning you can't have a constant go. There has to be a rotation because they need to cool down. So they're the problems of the x-ray, the big x-ray in the base hospital. Now we see this thing, all right, the mobile x-ray. And you can see that it's on a vehicle attached to the side. You can see in this brilliant photograph, there's an actual soldier having an x-ray used by the power of the vehicle, all right? So that, again, the nurses will probably drive these things around. And this was like about sort of 1916, halfway through the war, these things start being produced in an increase in numbers because of the value of them. And they become available in most of the CCSs, but certainly the bigger ones, and they're fitted on the back of these ambulances. Some of the hospital ships also had some mobile x-rays on. The fact of the matter is these things are now available and they are going to help save lives because they're going to help us locate, aren't they, shrapnel and bullets and other debris much, much quicker. All right. So some of the features of the mobile x-ray that you'll need to know for your knowledge for question 1 or for the source question is they take up a lot of time to set up. That's the thing. That's one sort of negative of it. But there's a useful way that you put this tent on the back. There's a table and a stretcher and the soldier can go on, and it's all run using the engine, all right, the power of the engine. The equipment for processing the x-ray films, they're inside the van, so again, quite clever, but they take time to set up as well. So it's not a quick thing. You don't just rock up in the mobile x-ray and take a picture. It takes a while, but at least we can do it. And the quality of the pictures aren't as good as the main x-rays in the base hospitals. But listen, if we're just looking for some shrapnel and some bullets, it's probably sufficient. So it's progress. And as with anything in these things, initial progress, it may not be amazing compared to many years later, but at least it shows that it's possible. And of course, there was a problem. And with problems, we need to find solutions. And here we have the mobile x-rays. So another really exciting progress in World War I for medicine and surgery. So source C is from radiography and radiotherapeutics, Robert Knox. He publishes this during the war in 1917. It's a textbook on the use of x-rays written by a British doctor. So this is going to be obviously the purpose of that, if we were looking at Provenance, is to train doctors and nurses perhaps how to use the thing. So therefore it's going to be really useful, isn't it? Because why would they tell you to do the wrong thing? So you can have a little read of this source. It just describes how it works, how it's connected to the thing. And there's a dynamo that sort of runs the processing of the thing. And this is a good photograph as well, just like the other one on the previous page, to show you how the thing is set up and where the soldier would lie. So these nurses will be driving these mobile x-rays around. So let's think about this question now, this follow-up question again, using source C. I don't want you to have a go at it yourself. I want to give you just an example of how your answer might look at this and how it looks as a model answer. So again, remember, we have to pick out a detail, a quote. In this example, they've picked out a great development in the provision of motor wagons or x-rays. That's the source. And you're just picking out something from the source. So it should be really straightforward. Now, we're trying to find out more about the x-rays on the Western Front. That's the focus. So that's a good detail to pick out. Now, our question would need to relate to that detail. And we can see the question that's been asked: how many x-ray vehicles were used in 1917 on the Western Front? Remember, we've said that question needs to be big and vague. that is as big as it gets. It's asking about the whole Western Front, isn't it? Then the source that we can use, obviously we say most of our sources we'll use here will be RAMC medical records from a CCS or base hospital on the Western Front. In this case, it's not appropriate. So you just have to use your knowledge of other sources. But the example here are military records this time, not medical records, showing the number of X-ray vehicles being used in 1917 on the Western Front. So again, we're nice and broad in there, and how that's going to help answer your question. The data will show whether the numbers increased and whether this was a great development. Obviously, you'll be able to see in the records that by 1917 they were using more than they were using before, and you could then assume that it was a progress and a good development. So hopefully that makes sense, and that's us now done 2 little practices of the follow-up question in this lesson, hopefully to start getting your confidence up a little bit. All right, so we've also now, just to pause before we move on to the rest of this lesson, we've looked at wounds, how we've dealt with wounds and infections. We've looked at broken bones. We've looked at the x-rays. So now we need to look at head injuries and brain injuries, okay? Now, again, these things are really common. We're aware from our injuries, aren't we, from the shrapnel balls that come, and also shrapnel that hit us in the head when they rain on from up above us. The Brody helmet helped significantly, I suppose, in terms of not having a Brody helmet, but we're now looking at inside the head, brain injuries, okay? So this is something to think about in terms of more unique, I suppose, more serious injuries as well. So 20% of all wounds in the British sector of the Western Front were to the head, face and neck, all right? That's obvious. That's the bit, again, like the arms and legs, that's the bit that's out to be more vulnerable. And they're the least protected bits, okay, from bits flying all over the show. Injuries to the brain are likely to prove fatal at the start of the war, A, because it's the brain, but also at the start of the war, infection applies to the head as much as other parts of the body. Now, we haven't got Carol Dakin yet. We're doing those basic things. We, as he said at the start of this lesson in the source, put pressure on, do the best you can. But the infection spreads really, really quickly, often before they've even got to the ADS, never mind the CCS. And obviously moving the men, the difficulties involved in moving men with head injuries through the evacuation chain in terms of them probably being unconscious or very confused, maybe lashing out, just not very easy at all, adding to the problem. And there are less neurosurgery, neuroscientists, neurodoctors, doctors who are specialists in the brain and the head and the spinal cord. There's less of them as the war goes on. Maybe people get more experience with this kind of injury and so naturally just get better at it. But at the start of the war, that's one of the problems and why most of the people who have a head injury or a brain injury would die. All right, so some facts to think about, and we're going to look at Harvey Cushing a couple of times in this bit of the lesson. He's got some interesting sources and some really incredible experiences, but he comes up with this new technique in brain surgery on the Western Front using magnets. So they use these magnets to try and pull out fragments of metal, like maybe not whole massive chunks of shrapnel, but certainly metal fragments, and maybe a bullet that's perhaps a bit smoother going in might be easier to pull out than a jaggedy bit of shrapnel. They used local anaesthetics when operating, as general anaesthetic made the brain swell. Now, this is one of those interesting things that they only learned because it happened. So by putting people under general anaesthetic where they're unconscious, the brain swelled a bit more, which obviously made it more dangerous to do the operation on there, but also harder to do the operation full stop. So Cushing starts using just local anaesthetics when operating, so the men are awake. As he observes, he learns more too. So he operates on about 45 patients with some of his new ideas in 1917 with a 71% survival rate. This is incredible, all right? So some of these new techniques and just the fact of using local anaesthetic has probably helped as well. And then it goes on a little bit more detail as well for the features of this, for your knowledge of the head injuries and brain surgery. Brain and head surgery becomes part of the routine treatments at the bigger CCSs. This isn't new to us. We know that as the war went on, the CCSs started doing more complex operations, and that took pressure off the base hospital. And that's just because they got so good at it, because they had so many bodies to do it on and practice on. But really, the reason why the CCSs picked this up is because they knew, it was very clear, the sooner you treat a brain injury with infection, the higher chances of survival. By the time you get to a base hospital, that infection has possibly done its damage. All right. They also will remain at some of the bigger CCSs for about 3 weeks following surgery, and all head injuries were carefully examined, much more than before 1917. This is where they realised some of the problems, and this is Harvey Cushing's sort of gift to the medicine, if you like, is he noticed things and he changed things because they weren't working particularly well. And sometimes by just moving these soldiers a little bit too quickly after an operation for a fairly minor injury could end up causing more damage. But also, sometimes didn't even look like anything was that wrong, but inside of the head, inside of the brain, there was some damage as well. So that little bit of careful examination before moving them on has also helped to save lives too. Okay, so this little table is really a summary of the problems and the solutions, and obviously that's what we're looking at in this whole medicine course, aren't we? And medicine and surgery in the trenches too. So the first thing that Cushing's realised is that men who are operated on quickly are more likely to survive. The method for doing this is specific casualty clearance stations was chosen as brain centres. So if you were lucky enough to be identified earlier on that you've got a head or brain injury, then you probably would go to the CCS that can deal with you rather than a random one that perhaps is more specialist in chest injuries or leg injuries. Also, they realised it was dangerous to move the men too soon after the operation, so they remain at the CCS for a few weeks. And then injuries that looked fairly minor could be hiding more severe things, so they did far more detailed examinations. So there were the problems. 1917 comes along, Harvey Cushing comes along, and they start doing a bit more observations of these things, and people are surviving. As always, it's about trial and error, I suppose. That is another nice little bit of information that you can include in your knowledge in the COP part of a source question. I know that. This is useful. And then for question 1, quite simply, a feature. All right. So this is another chance for you to practice a source question. So pause the video and answer in the purple box those 3 little activities. Again, this is from Harvey Cushing, who, of course, he's the one who's coming up with these ideas. So what an amazing source to get it from is his journal. Journals are going to be used, aren't they, for teaching and learning. So they're going to have to be detailed and they're going to have to be accurate. And of course, they're his experiences. He's writing down what he's noticed, and he's using these experiences, isn't he, to change his methods as the war goes on. All right. It's quite a descriptive source, this one. He's talking about one of his prize patients, Baker, who comes in with a shrapnel ball removed from his brain. Just look at it. Answer those questions as best as you can. Try to think a little bit outside the box. Remember to use your inference skills as well. What do you think's happened to make his temperature rise? Why is this guy a prize patient? Why does Cushing love this guy? What is he able to do on him? What's he learning from him? And what are the problems that the surgeons were facing on the Western Front? So this is a really important activity, not necessarily a source analysis one in terms of COP, but of just you doing skills and being a historian. What can you work out from this source, all right? And it's the same kind of thing as if it was a how useful is this source question, because it's teaching you something. You're learning something about the topic from a source. And straight from the horse's mouth as this one goes. All right, so unpause the video when you're ready and we'll carry on. Plastic surgery. Okay, so this one is really cool now. This is a major breakthrough, an amazing advance in the progress of surgery. And this guy here, Harold Gillies, is the pioneer of it all. He's the guy who's doing it all, all right? So we know from our injuries lesson that these soldiers got some absolutely horrendous injuries. We know that. Their faces were missing, bits of their jaw was missing, horrendous injuries that, of course, would probably have them dead. All right, and if not dead straight away, dead later on from complications. So Harold Gillies develops this plastic surgery. Then he's an ENT surgeon anyway before the war, so ear, nose and throat. So he kind of knows that area of the head pretty well and the inside of the head. And he's sent to the Western Front in 1915. Head injuries that didn't kill could cause this severe disfigurement that we've seen. And this led Gillies to become really interested in it and facial reconstruction and plastic surgery. Today, obviously, plastic surgery is used a lot for injuries, obviously, as well as cosmetic reasons. But the skills of it were definitely introduced and I think enhanced in World War I. All right, so these operations, they're quite intricate and they're too severe to be done in France. All right, so Gillies comes home and designs this hospital in Sidcup in Kent, the Queen's Hospital, which is essentially the specialist place for plastic surgery. And by the end of World War I, 12,000 operations had been carried out. So in the rest of this lesson, there's going to be some images from Gillies, his books and his works and his notes as he was doing these operations. Some of them are a little bit squelchy, graphic, if you want, for a better word. So just be prepared for that. And let's have a little think. So this is 4 photographs of one soldier. All right, his cheeks were extensively wounded during the Battle of the Somme in 1916. So to remove the picture now, you can see the damage that that's caused. Now that is utterly horrific, isn't it? But as you can see over time, Gillies is able to reconstruct this guy's face. Now, of course, the end picture is not perfect, but it's a lot better than it was. And before Gillies and before plastic surgery was being used on a bigger scale in World War One, that soldier may well have died from complications. And of course, if he went home looking like that, his life really would never be the same again. So progress and techniques and trial and error, of course. Patients did die under Gillies. Some did get infected. Skin grafts didn't take and things like that. But the point is, a lot of this is trial and error, because as we've always said in this course, basically they're going to die anyway. So this is another image of a gentleman who had some severe damage and some of Gillies' techniques. If you missed the lesson, then in the Google Classroom there'll be a video that shows you a story about this man. How Gillies started using tube pedicles to try and keep blood supply going as new flesh and skin grew, and they'd use bits of ribs in the forehead to replace the nose. Honestly, just the most mind-blowingly incredible thing. If you're watching this and you're in year 11, you're revising, and you want to see that video again, just let me know. I'll put it in the Google Classroom for you. But it is an incredible video. Or just YouTube World War One plastic surgery, Harold Gillies, and all of those videos will come up. But you can see it looks horrendous, but it was just mind-blowing. And we're talking about very early on here, in horrendous times in the war, but the outcome of this, the progress and development of surgery, especially plastic surgery, just incredible. All right, so World War One does have a part to play in that for sure. To me, it just blows my head how brilliant this Harold Gillies work was. Again, graphic images. You can see we've looked at these things already, but the damage that shrapnel can do and the war and the bullets and all sorts of things can leave you absolutely disfigured beyond all recognition. And then with plastic surgery, we can see slowly but surely, stage after stage after stage, people are improving and having a good time of it, or better time of it. Good time is not the word, is it? All right, so again, a little source opportunity for you. Pause the video, do a full-on cop of this source. So pick out some content. And the focus of the question is casualties being treated on the Western Front. So pick out some content, a sentence that tells you about casualties being treated. Add some old knowledge from this lesson that we've talked about, and then discuss the provenance. Who is Cushing? Why is his journal more important? Things like that. Just a perfect answer. And then hopefully you'll be, by this point, because this is the end of the course now, you'll be really confident and comfortable in doing these COP analysis. And remember that in the exam, you just got to do 2. All right, so 2 sources. You have to say how they're both useful for a specific focus. In this case, it could be 2 sources focused on treatment on the Western Front. All right, so this is about plastic surgery. When you're ready, unpause the video, and then we'll carry on and just draw this lesson to a bit of a close. All right, before we do end this lesson, just a reminder of the blood. This is the progress. We've done the blood at the beginning of the course anyway, but the changes in blood. But just to remind you, this was because of the war. So we realized, don't we, quickly on that if you add sodium citrate to the blood, it stops it clotting. And then if you add glucose citrate, it gives you up to 4 weeks of blood. So they storage, so they could do that before a big battle and have loads of blood. And then as that went on, Jeffrey Keynes, remember, developed the portable blood transfusion kit that they could take out onto the battlefield. And then in the Battle of Cambrai, obviously, we know, don't we, that they saved 50% of the soldiers using these mobile blood banks. So this is just a little reminder. So pause the video just to read those 4 boxes again, just to consolidate your knowledge of this course. And then, as always, a little summary from the textbooks that we've used in class that we use for our courses. That is the end of the Trenches course now, so we're now ready to move on to the next exam unit. But just make sure in this lesson that you have fully understood the advances, the progresses. Make sure you know the stories, that you can tell them confidently as part of your own knowledge, or also just for features. As ever, if you do have any questions, please let us know. And all of our lessons, just a little reminder, are available on our website, stchistory.com, as well as all other lessons have been recorded as well to help you with your revision. All right. If you do have any questions, if you're watching this because you missed the lesson, just let us know. All right. Once again, thank you very much, and we will see you on the next video.